For the sake of the time, we have to go on for the next speaker in this interesting session. It's my pleasure to introduce my dear friend and colleague, Professor Dr. Ahmed Shawky from Ain Shams University. He is going to discuss with us the management of hyperkalemia and heart failure patient.
Thank you for the introduction. Thank you for having me, Professor Mahmoud Hassanin, Professor Mohammed Sobhi, and the whole team at CVRAP. Good evening, everybody. I know it's quite late, but please, this is quite important what we're going to discuss. If we can get the slides up, great, thank you. And we've been discussing a lot, and one of the biggest problems that we have is not reaching our goals in heart failure. What is our goals is improvement of outcomes and improvement of the patient's status. And the patient's status and outcomes are related to the up-titration of medical therapy, and this is important. Even with the best of medical therapy, we still have unmet needs. One of these unmet needs is actually increasing the dose of medications. Why is that? Because we have a lot of medications within the heart failure with reduced ejection fraction, at least armamentarium, which have an impact on the kidney function, but mainly on the potassium. And this is quite important to take. And if you look at data on if you have a patient with kidney disease or without kidney disease, actually kidney disease worsens heart failure regardless of the cause. And we know there is an interrelationship between kidney disease and heart failure. There's the cardiorenal syndromes. There's a lot of factors that interplay that cause an interrelationship between the kidney disease and heart failure and vice versa. And thus, they share a common pathophysiology and they share probably a lot of their side effects. We know the cornerstones today have been said maybe 20, 30 times are the RAS system modulators, including the ARNI, of course, which is now considered a RAS system modulator plus sacubitril, beta blockers, and MRAs. The problem is a lot of the patients in these trials were excluded, those with a low GFR. Maybe the lowest GFR was seen with Emperor reduced, which was above 20. So people with kidney disease actually were not really included that much. And this really makes us a little bit weary on how to manage these patients. Second of all, they were talking a lot about the creatinine, and we talk a lot about creatinine. Actually, the most important is the eGFR or the GFR. And sometimes even nephrologists just say, don't just use that as a surrogate endpoint. You can use other endpoints like cystatin C. So we know discontinuation or reducing the dose of RAS system modulators has a high mortality rate. Not only bad for symptoms, it's bad for patients' well-being or living. And chronic kidney disease on the rise, so is diabetes, so is heart failure, and all of them affect the heart, the kidney, and the potassium levels. Of course, we're not going to see a lot of patients with these changes in the ECG. We're not going to wait, of course, till the patient has a severe hyperkalemia with these widening of the QRS complex being peak T waves. Usually, we see the patients with more symptoms than we see with different end organ damages. So what is the incidence of hyperkalemia? This is quite important. Actually, we're not actually 100% sure. It could be very low, it's just under 1%, and in some cases more. Why is that? Because the definition of hyperkalemia in different studies was different. مرة يقولوا above 5, مرة يقولوا above 5.5, مرة بيقولوا above 0.6 millimoles. So this is quite different, and this slide is not for me to explain something, but to show the heterogeneity of the definition of hyperkalemia. But actually, we have data to say it's around 2.4 per thousand or 11 per thousand, just under or around 1% or just below 1% in certain cases. So let's take an average of 1%. So it does occur, and it does hinder the up-titration of medications, thus the good well-being of patients. One of the important things that we don't take into consideration, why are we taking a history from a patient? Why are we collectively taking data from a patient? Because there are risk factors for hyperkalemia. The older the person is, not only does his GFR go down, but also the incidence of hyperkalemia may go up. What if it's a baseline hyperkalemia? How many people in heart failure actually do a baseline potassium and sodium levels? Not a lot, actually. In outpatient clinics, the data all over the world is quite outstanding, it's quite low. Of course, if the patient has a renal problem, diabetes, of course, this increases, of course, the hyperkalemia. Another thing is the dietary potassium that could be linked to certain increases in the hyperkalemia, like certain fruits, like bananas, some vegetables, some energy or sport drinks, nuts and cereals. These also add to the potassium. We are not also monitoring what our patients are eating and what they are doing, and this also impacts the hyperkalemia and increases the problems there. But one of the most important causes, important for hypertension and important for hyperkalemia, are the drugs. Non-steroidal anti-inflammatory medications are one of the most important medications that can cause gastric ulcer, can cause hypertension, can cause renal disease, and also can cause hyperkalemia. Of course, there are others like the immunosuppressive medications and the antifungals, so we should be aware what our patients are taking, not only in their food, but also their meds. We come to the second thing. Let's say we did a baseline potassium level. Should we monitor? Actually, the guidelines say yes. We're not doing that as much. It should say within a week from the initiation or the up titration dose, we should do a potassium level to check and also check the renal function. This is not really what's going on in the world. And the ACC, since 2013, I'm not going to update it, I'm talking about 7 years ago, they're talking about 3 days, 1 week after initiation therapy, and at least monthly for the first 3 months. And then you can do it every 6 to 1 year. Actually, are we doing this? Not a lot. So this is another problem. We're not initiating correctly, checking, the potassium levels correctly, and we're not following up. So what if we have a hyperkalemia? Does this require us to stop the medications? We just said stopping the medications or down titrating increases death. Actually, there are several medications like the calcium, giving sodium bicarbonate, glucose and insulin, and diuretics. These are very simple, very available, simple to use, but actually they do have a little bit of side effects. But there is a paper just published a couple of years ago, it's not so recent, but it was talking about how to reduce the risk of hyperkalemia. And the number one thing is try to use an ARNI. There is data, I'll show it to you. There are novel mineralocorticoid antagonists, and using the binders of potassium, be it the sodium polystyrene sulfonate, the parteromer, or the sodium zirconium cyclosilicate. And we can see in ARNI, in the paradigm heart failure, when comparing sacubitril valsartan to enalapril, the incidence of hyperkalemia was significantly reduced. Finerenone, a novel mineralocorticoid antagonist, still not FDA approved, but in the ARTS heart failure study, the incidence of hyperkalemia was less. Of course, this is still not on the market. We have potassium binders, like the cation exchange resin, sodium polystyrene sulfonate. It exchanges sodium and potassium, and this is a good medication, but it does have some gastrointestinal complications, and this is a problem that really causes a lot of patients to discontinue the medication. Its selectivity also is not that high, and actually the way it works mainly is not in the entire gastrointestinal tract, so that's why it has a little bit of bad effects more than parteromer or sodium zirconium. This works mainly in the distal colon, and the distal colon has the highest levels of potassium in the colon. And it has shown in studies like the OPAL HK that it can reduce potassium of up to very quickly, that's number one, and also up to 1 milliequivalent per liter. And this is important to take into consideration. So it works quicker, within hours, it is persistent, and we have data to say that it maintains normal potassium levels up to a year. So this is a good thing. So instead of down titrating or lowering the dose or stopping even the mineralocorticoid antagonists, the RAS system modulators, we can use potassium exchange resins that can help us. But the newest kid on the block that we don't have, it's present outside of Egypt, and hopefully I think it's AstraZeneca's medication, they'll bring it very quickly, is the sodium zirconium cyclosilicate. It's odorless, tasteless. It works all over the gastrointestinal tract, and it's counter-ion and working to reduce potassium, and it works within a couple of hours. So it's very quick and very persistent, and this was seen in the harmonized. Its structure is an inorganic crystalline. It's not a polymer, highly stable, does not expand, does not let the colon expand when you give it. And this was a problem with the first medications. It's not systemically absorbed, and this is very good. And as previously said, it is highly selective for potassium than others. Its efficacy has been shown through the harmonized study, and it does work grading the dose of zirconium silicate. And of course, it is quicker than Potassium in the onset of action in a couple of hours. But of course, there are no head-to-head comparisons to say which one is better than the other. Again, as I showed, a couple of hours, there's a significant reduction with this potassium binder. But the question always arises, are these medications safe? And yes, data shows us here that they're very safe, especially the Potassium and the sodium zirconium silicate. And if we just take an overlook on the potassium binders, we can see that they have a little difference in their action. The SPS or Potassium work on the colon mainly, the Potassium mainly in the distal part of the colon, but the sodium zirconium works all over the gastrointestinal tract. Sodium zirconium works much quicker, within a couple of hours on average, compared to 7 hours or days even in SPS. So this is important. Also, the effects or the side effects are a little bit more in the SPS than the sodium zirconium or Potassium. So actually, medications that we give work on several mechanisms. We can see on the top left, insulin and beta blockers, actually beta agonists, sorry, can work on the sodium potassium ATPase and reduce potassium levels. Bicarbonate that we give in hyperkalemia works on the bicarbonate potassium cotransporter. Loop diuretics, which we use sometimes to reduce, of course, potassium, which should have been used as decongestants only, work, of course, on the kidneys. But working on the potassium exchangers on the down right, you can see that they work on the gastrointestinal tract. So thus, you are not having problems with your medications. So I just want to say, hyperkalemia, when it occurs, even with RAS system blockers, does not eliminate their survival benefit. And this is seen even with MRAs, and this was from the emphasis heart failure. But mortality is increased if you reduce the RAS system blocker dosage or discontinue them. So not to take a lot of your time, our cornerstones of heart failure has always been the RAS system modulators and the MRAs, and they have reduced morbidity and mortality. We've seen this today several times. But the problem is that we might have been faced with some problems like chronic kidney disease, hyperkalemia, and this usually has an impact on the physicians to discontinue the medications, and this could really worsen the patient's outcomes. We should look for the patients, their risk factors, what are they taking, be it in their diet, be it in their concomitant medications. Monitoring, just at least 1 week. I'm not going to say every couple of days, at least a week. Like just the guidelines we're talking. This is quite important to follow up our patients and to make sure. And up titrating, of course, bit by bit, this is the way to go for heart failure. Maybe the newer approaches like the ARNI may reduce the potassium elevation that might occur, some new MRAs, but definitely the potassium exchange resins can be there if you have a patient with hyperkalemia. And I reiterate, hyperkalemia does not affect the outcomes even if you use a potassium exchange resin. No, you're benefiting the patients more and more. Thank you.
Thank you, Dr. Ahmed, for this elegant presentation as usual.
Thank you.
I'd like to ask you one question. You have a lot of measures that reduce the potassium level. In acute situations, what would you like to recommend to give something like calcium chloride or hemodialysis for a rapid and immediate reduction of the potassium level in an urgent way?
Oh, this is very important. We've seen this in the ER several times, and the patient might present with a complete heart block or something like that. We give immediate bicarbonate, calcium injection, or we can give glucose insulin. This acts very quickly, but of course, if you have a persistent elevation of potassium, this might warrant ultrafiltration or hemodialysis, but this takes time. These other medications work very quickly. Do we have data on sodium zirconium in acute situations? I don't think so, because this depends on the concentration of potassium within the colon and the gastrointestinal tract, not only in the blood, but definitely in the emergency we use these intravenous medications like calcium, like bicarbonate, and glucose insulin.
Thank you, Professor Ahmed. An excellent presenter as usual. I ask about a real life situation where actually the potassium binders are not available, and if not available in some centers or most of the centers, the cut-off point of potassium level to stop or to reduce the dose of the drug, and which drug to omit. Yeah, the patient with heart failure receives RAS system, whether ACE, ARBs, sacubitril valsartan, and mineralocorticoid receptor antagonist. Both drugs raise the potassium level.
Definitely.
Which drug to omit, and at what level you decrease the dose of ACE or ARBs?
Okay, if I don't have a potassium exchange resin, okay,
Yes,
we have at least the SPS. It sometimes comes, it sometimes goes. We don't have the others. I would probably, and this is not data, this is personal, I would probably reduce the dose of the MRA or reduce the MRA instead of the ACE or the ARBs first, and then check. What is the level? We have a lot of discussion with the nephrologist in Ain Shams University. We do a lot of conferences with the nephrologist, and we use them a lot in our medications. They like to stop at 5 or reduce. We go to 5.5, and we're not a little bit scared. But they're, of course, a little bit more cautious than us.
I agree with you. If we revise the guidelines put ACE and the beta blockers the first, and then mineralocorticoid receptor antagonist if it's feasible. But if the potassium level above 5, we can omit mineralocorticoid receptor antagonist and continue by ACE and the beta blocker. If it's still potassium high, we can reduce the dose of ACE. Or this is practice. Yeah, this is our practice.
Thank you very much. There is no interaction between beta blockers and the potassium level. What do you think?
I beg your pardon?
Beta blockers, yeah.
Beta blockers, well, there's a lot of data on the beta blockers and the effect on the kidney. There's also on potassium. If you're looking at what is the safest beta blocker when it comes to chronic kidney disease, there are no contraindications, but carvedilol may be the safest beta blocker. But yes, beta blockers can affect or can be affected by kidney function or potassium levels, yes. And they can affect the potassium levels.
The definition of hyperkalemia is roughly taken as 5.5.
Yep.
Do you think, should we consider it as a single figure, or it is a range, or the definition may be variable according to the patient profile?
That's quite good. That's a very good question. The average, actually, Professor Walid, this is a very good question. The average of the studies I showed were 5.5. There were studies that showing at 5 and studies at 6, actually. And the data from sacubitril valsartan in the paradigm was at 6. It wasn't 5.5. So I would go for 5.5 as a part. لكن بتوع النفرولوجي وهم حبايبنا وعلى راسنا من فوق بيخافوا من أول 5. Not to say that 5 is hyperkalemia, but should warrant follow-up.
And should we take, thank you Ahmed for
this
presentation, and should we take the value of 5.5 as a cutoff value for the use of the new potassium binders?
I cannot say this, I'm not sure. What type, when to use them, in what grade, I'm not sure. Should I change the ACE inhibitor to sacubitril valsartan and then check? This is part. Maybe I would use an increase in the loop diuretics if the patient is already on loop diuretics. I wouldn't advise giving loop diuretics if the patient is dry. This is another thing. But yes, if it's above 5.5, above 6, maybe potassium exchange resins are the best.
Sorry, Dr. Ahmed, to complete my comment, before we omit the drug or the reduced dose, as you mentioned, we have to look for other causes of hyperkalemia
Definitely.
before we change a drug.
Definitely.
Non-steroidal anti-inflammatory drugs, diet. Sometimes the patients, the hypertensive and heart failure, and use potassium-containing salt instead of sodium chloride.
Yes.
So this is important to check the concomitant drug therapy, to check the diet before we decide to change the drug.
Totally agree. Thank you. Thank you.
بس one comment one يعني small
Thank you.
question أخير. هل لاحظت في different response of hyperkalemia in the same subset of group of patients with chronic kidney disease and different response to hyperkalemia at the same level of hyperkalemia?
At
You
the
find
similar,
different
similar
response?
what? Sorry, معلش.
We have some patients tolerating hyperkalemia
Yes.
for some time, and some patients may not tolerate.
Definitely, but when potassium elevates, it's quite, it's more dangerous even than the GFR going down. Potassium is lethally an arrhythmogenic, its elevation or even going down is arrhythmogenic and can cause a lot of problems. But yes, different patients, yes, we see patients coming to the ER with a potassium level of 7, and they're just discussing another problem, not really related to the potassium levels. Yes, this we see.
Okay. Thank you
Thank
very
you.
much, Dr. Ahmed.